Hello all, my name is Akshitha and I am Assistant Professor from the Department of CVT, Yenepoya School of Allied Health Science. Today we will be studying on the topic rheumatic fever. Coming to the specific learning objectives, so here we are going to understand what is the etiologies, what is the morphology and classification of valvular, and also what is the relevant screening and also the diagnostic tests which will help in the clinical findings, and also coming to the conclusion regarding the cardiovascular risk stratification. So moving on to the contents of the rheumatic fever. So mainly we will be going to look into the prevalence, causes, pathology, history. Under clinical manifestations, we are going to see the major and the minor manifestations, and also we are going to look into how we are going to diagnose this rheumatic fever and also the management strategies. Now, coming into the actual prevalence of this condition, that is the rheumatic heart condition. So mainly it occurs in 5 to 15 years of age. That is the main duration during which the rheumatic fever usually comes. So it occurs rarely in less than 3 years of age. So who are most commonly affected by this is usually the girls. Girls are most commonly affected by the rheumatic heart fever than compared to the boys, usually occurring between the age of 5 to 15 years. So what is the main cause for this acute rheumatic fever? So here the main cause is nothing but it is the group A beta hemolytic streptococcal infection. Okay, so it is also called as GABHS, which is nothing but the group A beta hemolytic streptococcal infection. So what is a acute rheumatic fever mainly causing? It is a immunologic response that occurs as a delayed sequelae of a group A beta hemolytic streptococcal infection of the pharynx. So whenever this infection is going to be affecting the pharynx, this is a late sequelae, that is acute rheumatic fever is going to occur as a late sequelae. So what is the important predisposing factors if the acute rheumatic fever has to occur? One of them is nothing but the family history of rheumatic fever. So if the person who has got the acute rheumatic fever already has a family history of rheumatic fever, then they have a higher chances of getting the acute rheumatic fever. And also if the person is having a low socio-economic status. What does that mean? If the patient is under poverty or poor hygienic conditions, then they have the higher chances of getting acute rheumatic fever, and especially if they are in the age of between 6 to 15 years, they have very high chances of getting acute rheumatic fever. So through this one main PPT, you will know that the main cause is nothing but the group A beta hemolytic streptococcal infection, which is mainly occurring between the age of 6 to 15 years. Moving on to the pathology. So what is the pathologic condition you're going to see in acute rheumatic fever? So here you can see that there are inflammatory lesions. Okay, inflammatory lesions are found in the different parts of the body. So acute rheumatic fever will be affecting not only the heart but also different parts, which includes the heart, brain, joints and the skin. Okay, so these are the affected areas, and you can see different clinical manifestations associated with this condition. Rheumatic carditis is considered to be pancarditis. What is pancarditis? It includes also the myocardium, endocardium as well as the pericardium. So all these three things will be affected. Whereas myocarditis is going to be the most important element in the carditis. In rheumatic myocarditis, myocardial contractility is rarely impaired. Okay, it is rarely impaired. You can see that valvular damage is most frequently seen, especially the mitral valve. Okay, so especially the mitral valve will be affected, and less commonly you can see that the aortic valve is affected, tricuspid and the pulmonary valve is affected. So that is the important thing to be remembered in rheumatic carditis. Ashkoff bodies in the atrial myocardium is believed to be the characteristic of the rheumatic fever. So you can see in this slide there is something called as Ashkoff bodies, that is nothing but the areas of fibroid necrosis. So if this is present in the atrial myocardial region, then it gives a clarity or the information that the rheumatic carditis is for sure present in the patient. And you can also see something called as antiscoff cells, which is the enlarged macrophages. So in that you can see something called as caterpillar nuclei. Okay, see, these caterpillar nuclei is nothing but there are more than one number of nucleus present in that macrophage. So this is nothing but the antiscoff cells, which can also be seen in case of rheumatic carditis. So moving on to the pathogenesis. So in pathogenesis, what happens? As I've already mentioned to you all, it is a delayed immune response to the infection with a group A beta hemolytic streptococci. So what happens after a latent period of 1 to 3 weeks is when you can see that there is a immunological damage which occurs in the different parts. That is the heart valves, you can see there is a damage. You can see damage in the joints. You can see damage in the subcutaneous tissues as well as in the basal ganglia of the brain. So this is nothing but the pathogenesis, which usually occurs in the after a latent period, which is 1 to 3 weeks. Latent period is nothing but there is a delay in the results. Okay, once the infection has come, there will be 1 to 3 weeks of gap, and then only you will start seeing the signs and symptoms. What are the very common features suggestive of group A beta hemolytic streptococci infections? So first thing you have to notice, the patient or that person will be usually between the age of 5 to 15 years, and also the presentation or the clinical presentation of this condition usually occurs during winter or in the early spring time. Okay, this is the season when you usually see this clinical manifestations. What are the other signs and symptoms you can see in the patient? One thing is they'll be having fever, headache, and there will be sudden onset of sore throat. Okay, sore throat will be there. There will be nausea, vomiting and abdominal pain, and also pain while swallowing. So beefy, swollen red vulva will be there. I'll show you the images in the coming slides. Soft pellet petechiae will be there, that is donor type of lesions. You can see that tender, large, enlarged anterior cervical nodes will be there, and also tonsillo-oropharyngeal erythema and exudates will be seen in the patient. So you can see in this image, in the first image you can see there is redness and swelling of the throat and the tonsils, and in the second image you can see there is a beefy swollen red vulva, or you can also call it as soft pellet petechiae. Okay, donut lesions can be seen, and in the third image you can see that there is tonsillo-pharyngeal erythema and exudates. Okay, those arrow marks are pointed towards those exudates which are present, and sore throat is also commonly present in these patients. Moving on to the clinical manifestation. So what are the signs we can see in the patients? First thing is you have to remember while seeing a rheumatic fever is that there is something called as Jones criteria, which is very important to diagnose the acute rheumatic fever in a patient. So what does this Jones criteria include? Very important to rule out the acute rheumatic condition. So there are three main groups which are present, which has to be looked into whenever we are seeing the Jones criteria. That is, there are 5 major manifestations, there are 4 minor manifestations, and you have to also look into the supporting criteria, the supporting evidence of an antecedent group A streptococcal infection. So what do you mean by antecedent? It is also called as previously existing. So to check, to rule out if it was previously existing or not. So what are the main things you have to remember in the Jones criteria is there are 5 major manifestation, 4 minor manifestation, and also the supporting evidence is very important. So first, before getting into the actual Jones criteria, you should also see what is the history of that patient. I have already told family history plays a very important role. So history of a streptococcal pharyngitis, especially 1 to 5 weeks before the onset of the symptoms, is very common. So you have to ask and find out if the patient had any previous history of a streptococcal pharyngitis. Also, if the patient is having some signs such as pallor, then malacia, which is usually a generalized discomfort that patient is facing, then easy fatigability, and other histories such as epistaxis, which is nothing but the bleeding of the nose, and abdominal pain may be present in some of the patients. So all of these are present, then you have to move on to the consideration of the major and the minor criteria. So what are the elements which are present in the major criteria? So there are 5 major criteria as I mentioned earlier. So first one is the arthritis, second one is the carditis, third one is the erythema marginatum, fourth one is the subcutaneous nodules, and the fifth one is the Sydenham chorea. So these 5 are the important major manifestations seen in the patients with acute rheumatic fever. So what does this Jones criteria include? One, arthritis, that is related to the joints. Okay, first one you have to remember, arthritis is related to the joint. So what happens is here, the joints are affected. Okay, once the infection is come for the patient, then after the latent period, the first thing you can see is the joints are affected. So arthritis, the most common manifestation of the acute rheumatic fever, which occurs in about 70% of the cases. Okay, in out of 100%, 70% of the times you can see that acute rheumatic fever, then the patient will be having arthritis. It will be usually affecting the larger joints, which includes the elbow, knees, wrist, and also the ankles. So often more than one joint can also be involved. So what is that called? It is having a migratory nature, so it is called as polyarthritis. Okay, remember, it is called as polyarthritis if more than one joint is affected. So arthritis is nothing but the abnormality related to the joints, which occurs in about 70% of the patients affected with rheumatic fever. So what can you see? You can see that there is swelling, heat, redness, severe pain, tenderness, and also restriction in the movement, okay, whenever the patient is affected by arthritis. If the patient was given a salicylate which is containing analgesic, these signs of inflammations are usually mild. So the patient is having some joint pain, he will go to the doctor, and if the doctor prescribes him some analgesic, usually the signs of inflammation reduces, but it doesn't say that it is not a acute rheumatic fever. Next, moving on to the carditis. Carditis is nothing but related to the abnormality related to the heart, which occurs in about 50% of the patient. Most common is arthritis, which occurs in 70% of the patient, whereas carditis, which is abnormalities related to the heart, occurs in about 50% of the patient, and this is the most serious and is often regarded as the most specific manifestation of rheumatic fever. More serious as well as more specific. So it affects about 41 to 83% of the patients overall. If you consider the acute rheumatic fever, around 41 to 83%, and it may manifest as pancarditis. I already told that it will be affecting the endocardium, myocardium, and pericardium simultaneously. So that is termed as pancarditis. So what are the signs that the patient is having carditis is, first and foremost, you will see that there is tachycardia in the patient, MR or AR or murmur of both. MR is nothing but mitral regurgitation, AR is aortic regurgitation. So whenever there is regurgitation or leak, the murmur is expected. So you can see that either MR or AR murmur or both murmurs can be heard in the patient. Pericarditis is usually understood with the help of frictional rub, pericardial effusion, and also there can be ECG changes. So these are the signs that there can be pericarditis in the patient. Cardiomegaly. Cardiomegaly is nothing but the increase in the cardiac chamber size. So it is seen in chest X-ray. So if cardiomegaly is seen in chest X-ray, it is indicative of a severe rheumatic carditis or valvulitis, or it can be because of a congestive heart failure. Okay, so there is an enlargement of the cardiac chambers. Signs of CHF are indicative of a severe cardiac dysfunction. So CHF is congestive heart failure. So if these signs are present, then it is very indicative that a carditis is present in the patient. So the most common characteristic component of a rheumatic carditis is valvulitis. Valvulitis is nothing but the valves are affected. So what happens when the valves are affected? As I have already mentioned, the mitral valve is very commonly affected than the aortic tricuspid or the pulmonary valve. So when the valve is affected, it automatically does not allow it for the proper functioning. So you can see that there can be a mitral regurgitation, which is a hallmark. Okay, it is a hallmark of a rheumatic carditis. Aortic regurgitation is less commonly seen because it is less affected, but if it is present, then usually it is associated with the mitral regurgitation. So it will come side by side. So as a thumb rule, or a very important thing which you have to remember is, if the patient is presenting within the age of 30 years, that is less than 30 years, the patient is presenting with the isolated mitral regurgitation, then there will be only mitral regurgitation. The only thing you can see is the MR which will be present. But what happens as the age progresses, this disease condition becomes severe, and you can see that if the patient is presenting after the third decade, that is after the 30 years, there are high chances that the patient is also having mitral stenosis associated with the mitral regurgitation, which gives that the disease has progressed. Okay, so one thing you have to remember, less than 30 years, usually it is a mild form, which is mitral regurgitation will only be present in various degrees. But if they are presenting with greater than 30 years of age, usually the mitral stenosis is also present in the patient. Moving on to the third major criteria, that is erythema marginatum. So it occurs in about fewer than 10% of the patients who are affected with the rheumatic fever. So it is a non-purpuritic serpiginous, which means that it doesn't itch. That particular erythema marginatum condition, it will not be itchy rash, it will be just present. There will be rashes present on the body, or it can also be a erythematous rashes which are prominent on the trunk, that is the thorax region, and the inner proximal portions of the extremities. Okay, in the proximal thorax region, you can see that there is rashes present which are non-itchy. Okay, they are also never seen on the face. You can only see them in the body, the upper thoracic region, but on the face it is very rare. These rashes are lasting for very short duration of time. So what happens whenever you are exposed to a very cold temperature, then these rashes will disappear, and if you are taking a very hot shower or you are covering yourself from a warm blanket, then it starts reappearing. Okay, so this is very present for a very short duration of time. So they are rarely detected in the air conditioned room. So because they are going to disappear with the colder when they are exposed to colder temperatures. So here you have to remember that it is a non-pruritic serpiginous or a erythematous rashes which is present in the upper thoracic region. Can you see the second image? So that is the erythema marginatum, which is present in the patients with the acute rheumatic fever. Moving on to the fourth one, that is the subcutaneous nodules. So here this is found in about 2 to 10% of the patients. So here you can see there are hard painless, again non-pruritic, freely movable swellings which are about 0.2 to 2 centimeter in diameter. So they are very small, so their size can vary. So usually they are symmetric, single present, or they can also be present in clusters. So they are present on the exterior surface of larger as well as small joints, or you can also see them over the scalp or along the spine region. Okay, so these are the areas where you can most commonly see these nodules, and subcutaneous nodules are not exclusive to rheumatic fever because they can also be present in some other conditions which includes the SLE and other conditions. Okay, so you can't say that just because the subcutaneous nodules are present it is very indicative of rheumatic fever. So it can also be present in some other condition which includes the SLE. So this is the rheumatic subcutaneous nodules, which is a swelling, and it will vary in size from 0.2 to 2 centimeter. Moving on to the last major criteria, which is the Sydenham-Chorea. So Sydenham-Chorea was previously called as St. Vitus dance. Okay, so that was the previous name which was told, but right now it is most commonly called as Sydenham-Chorea, which occurs in about 15% of the patients who are affected with the acute rheumatic fever. So it occurs especially in the girls who are around the age of 8 to 18 years compared to that of the boys. So most commonly affecting the girls. It is a neuropsychiatric disorder consisting of both neurological signs. Neurological signs is nothing but involuntary movements, purposeless movements will be there in these patients, and psychiatric signs. What is psychiatric signs? Emotional lability. So there will be so much changes in the emotions, like over a period of time they will be changing themselves so many times. Hyper reactivity will be there, then separation anxiety, obsessions and compulsions. All these can be the psychiatric signs which you can see in these patients. So Sydenham-Chorea is one of the important manifestations which in the Jones criteria. So it begins with the emotional lability, which is nothing but changes in the emotional behavior of the patient, and also the personality will start changing. So it starts with that, then soon it will be replaced within 1 to 4 weeks after the acute rheumatic fever has set. Then you can see that there is characteristic spontaneous purposeless movements of the chorea, which usually last for about 4 to 18 months, followed by the motor weakness. So there will be overall weakness in the motor system. So this distractibility and inattentiveness outlast the choreic movements. So what happens? The distractibility and inattentiveness usually will outlast the choreic movements, that is the purposeless movements. The adventitious movements, weakness and hypotonia continue for an average of 7 months. So once the rheumatic fever has come for the patient, these movements, these emotional lability, all these will be continuing up to 7 months or even up to 17 months, even when the severity has started to reduce. So these are the movement disorders which you can see in patients with Sydenham-Chorea. So these are the pointers to remember in patients with, these are the 5 major criteria which you have to remember in patients who are having acute rheumatic fever. Now we have already gone through the 5 major criteria which are very important. Now moving on to the minor manifestations. If these are present, then also you can say that they are having a chances of having the acute rheumatic fever. So first thing you have to see in this is arthralgia. It refers to the joint pain only, but the pain will be less compared to that of arthritis. So arthralgia refers to the joint pain without the objective changes of arthritis. It must not be considered a minor manifestation when arthritis is used as a major manifestation in making the diagnosis. So if you are considering that the patient is having arthritis, then arthralgia should not be considered in the minor manifestation. Next, moving on to the second minor manifestation, which is usually the fever. So if the temperature which is around 102 degree Fahrenheit or 38 degree centigrade, then in the early course of the rheumatic fever or the infection, then you can consider it to be a minor manifestation. In laboratory findings, then elevated phase reactants such as elevated CRP, that is the C reactive protein levels, elevated erythrocyte sedimentation rate, that is the ESR. If these are elevated, then you can say that there is elevated inflammatory process which is happening. So you can say the laboratory findings is also positive, which comes under the minor manifestations. Then a prolonged PR interval on an ECG is either specific for acute rheumatic fever nor an indication of a active carditis. So it can be present, but you cannot completely rely on the prolonged PR interval. So it is not very indicative of a rheumatic fever. Moving on to the evidence of antecedent group A streptococcal infection. So here what you have to know is if the infection was previously present or not, okay, that clue if it is there or not. So one thing is, a history of sore throat or a scarlet fever will not give you a complete evidence that there is a acute rheumatic fever. So what is important is the streptococcal antibody test is very important, which is a most reliable laboratory evidence of a antecedent streptococcal infection capable of producing acute rheumatic fever. Okay, so if there is a proper evidence that by a antibody test, then only you can say that there was a previously existing streptococcal infection of the pharynx. What are the other clinical features you are supposed to look into when you are seeing an acute rheumatic fever is abdominal pain. If the patient is complaining of abdominal pain, rapid sleeping heart rate, that is tachycardia, will be present, and also malaise, generalized weakness, anemia, epistaxis and precordial pain are relatively common, but they are not very specific of a rheumatic heart disease because these will be usually present in other conditions as well. A positive family history of a rheumatic fever may also heighten the suspicion. So it will not give you the 100% indication that this patient will be having rheumatic fever, but if there are family history of rheumatic fever, then they have a higher chances of acquiring it as well. Now, how do we apply the criteria, the Jones criteria? How do we diagnose that it is a rheumatic fever for sure? That is, you have to see the Jones criteria. The revised Jones criteria are used for the diagnosis of acute rheumatic fever. So the diagnosis of acute rheumatic fever is highly probable, it is highly present if either of the two major manifestation or one major manifestation and two minor manifestations are present along with the evidence of a antecedent streptococcal infection. So what does this mean? So when can you say the acute rheumatic fever is present for sure? One thing is, two major criteria should be present for sure. Okay, out of the 5, 2 major should be present, then you can say it is a acute rheumatic fever, or one major criteria and 2 minor criteria along with the evidence of the antecedent streptococcal infections. So if this is present, then you can say there is acute rheumatic fever. The absence of the supporting criteria, that is the group A streptococcal infection, makes the diagnosis doubtful. So along with the major criteria, minor criteria, the presence of the supporting evidence is very important to come to a conclusion for the rheumatic fever. The following tips will help in the applying of the Jones criteria. So you have to remember that 2 major manifestations are always stronger than having a 1 major plus 2 minor manifestations. So if the patient is having two major manifestations, then you can for sure say that the patient is having a acute rheumatic fever. And arthralgia or a prolonged PR interval cannot be used as a minor manifestation whenever you're thinking about arthritis and carditis. So you have to get the specific clue for arthritis and carditis than relying on these two criteria. The absence of evidence of antecedent group A streptococcal infection is a warning that acute rheumatic fever is unlikely. So as I mentioned before, the presence of the evidence of the streptococcal infection is very important. The supporting criteria is also very important, except when chorea is present. So you can see that the third point is exceptions to the Jones criteria includes the following. So if sydenham chorea is the only thing which is present in the patient, then it is suggestive of acute rheumatic fever. There need not be any other supporting criteria. Okay, sydenham chorea is enough to say that the patient is having a acute rheumatic fever. This is an exception in the Jones criteria. Indolent carditis may be the only manifestation in the patients who come to medical attention months after the onset of rheumatic fever. The indolent carditis is nothing but the symptoms, signs and symptoms will not be very evident in the patient. They will come for some other investigations and they will come across that they will be having some cardiac abnormalities. So that also comes under this category. Occasionally patients with rheumatic fever recurrence may not fulfill the Jones criteria. Okay, so that also you have to remember. Occasionally the patients with rheumatic fever recurrences may not be fulfilling the Jones criteria. So these are the guidelines. Whatever I have mentioned in the previous slide is put together. This is the guidelines of the diagnosis of initial attack of rheumatic fever. So this includes the major criteria, minor criteria as well as the supporting evidence. So all of this has to be noted to make a diagnosis or come to a conclusion that the patient is having the acute rheumatic fever. So this is how you can remember mnemonics to remember the major and the minor criteria. So for major criteria you can remember it as cases, CASES. So C stands for carditis, A stands for arthritis, S stands for subcutaneous nodules, E stands for erythema marginatum and S stands for sydenham chorea. So major means cases and minor criteria can be remembered as FRAP. Okay, FRAP is a mnemonic. So F is nothing but fever, R is raised ESR bar CRP, then arthralgia, P for prolonged PR interval and P for a previous history of the rheumatic fever. So if you can remember this, it's well and good, because this is a very important question which can come from the rheumatic heart fever, that is the Jones criteria. So it will be easy to remember cases and FRAP. So differential diagnosis of this condition. So differential diagnosis is nothing but what are the other chances? What are the other chances of having the condition? Nothing but differential diagnosis. First one is the juvenile rheumatoid arthritis. So it can be just a rheumatoid arthritis which is often misdiagnosed as a acute rheumatic fever. The following will be suggesting, the following features will be suggestive that it is a juvenile rheumatoid arthritis rather than the acute rheumatic fever. So one thing you have to see in this, involvement of the peripheral small joints. So I have already told acute rheumatic fever is going to involve the major joints. So in juvenile rheumatoid arthritis, the involvement of peripheral small joints is also seen. Symmetrical involvement of large joints without the migratory arthritis. In case of rheumatic fever, it is usually migratory as well. You can see that more than one joint is involved, but here you will not see that condition. Pallor of the involved joints can be seen. A more indolent course is seen. You cannot see the signs and symptoms soon after the involvement of the infection. No evidence of predisposing streptococcal infection. Very important feature, because we can come to a conclusion of a rheumatic fever only if there is evidence that there was a streptococcal infection. And the absence of a prompt response to salicylate therapy within 24 to 48 hours. So we have already known if salicylate is given as a therapy for the patient with the acute rheumatic fever, usually the inflammation will be reducing, but here in case of a juvenile rheumatoid arthritis, there will be the absence of this reduction in the pain or the inflammation. So these will suggest that it is a juvenile rheumatoid arthritis than a acute rheumatic fever. So what are the other differential diagnoses? It can be because of some collagen vascular diseases such as SLE, mixed connective tissue disorders, etc. It can be because of some virus associated acute arthritis, which is usually the rubella, hepatitis B virus, all of this, which is very common in the adults. Then it can also be because of some hematologic disorders such as sickle cell anemia or leukemia, which can be considered as, or which should be considered as, a differential diagnosis for rheumatic fever. Moving on to the management. So till now we have seen what are the causes for it, what are the manifestations, the major manifestation, minor manifestations, the evidence, how you will see supporting evidence. Then you also know how to diagnose a acute rheumatic fever. So once the acute rheumatic fever is diagnosed, now we have to treat it, because it should not progress to a condition where the patient has very severe symptoms, correct? So the management should begin soon after the acute rheumatic fever is diagnosed. So what is the management strategy which is involved? Benzathine penicillin G, that is 0.6 to 1.2 million units intramuscularly is given to eradicate the streptococci infection. This serves as the first dose of penicillin prophylaxis. Okay, soon after the infection is found out, you are supposed to give this prophylaxis medication, which is the benzathine penicillin G. Anti-inflammatory or suppressive therapy with the salicylate or steroids must not be started until a definitive diagnosis is made. Why? Because these steroids or salicylates are going to reduce the inflammation, so you will not be going to getting the obvious results. Okay, so when you give the medication, it will reduce the infection. So at that point of time, if you are going to do the diagnosis, obviously the result will be false or misinterpreted. So you have to make sure that until and unless the diagnosis is definite, these should be avoided in the patients, and therapy with anti-inflammatory agents can be done, that is aspirin can be given to the patient. So very important thing is benzathine penicillin G once the acute rheumatic fever is diagnosed for sure. One more thing you have to remember is whenever the acute rheumatic fever is diagnosed, you have to make sure the medication is followed up to 5 years or until the age of 21 years, whichever is longer. If the patient is diagnosed at the age of 20, imagine the patient is diagnosed with acute rheumatic fever at the age of 20. So which is longer? So you are going to give for 5 more years, which is 26 till the age of 26. But if the patient has diagnosed at the age of 12, then the prophylaxis should be given until the age of 21 years. So whichever is longer, for that duration of time, the prophylaxis should be continued for the patient. The same thing is mentioned in this table. So this was it. These are the references from which you can go through the more details of this acute rheumatic fever. Thank you.